Hi, everyone, and welcome to the show. This is a very special episode. We are honored to have a patient who has peripheral artery disease, which is that circulation issue that we talk a lot here on the show about, which can lead to amputation. And this patient is going to share his harrowing story of how his fight to save his leg. Also joining us is going to be his cardiothoracic surgeon, who has been fighting right alongside him in trying to save his leg. So you want to stick around. Don't miss this story, because I think you're going to learn a lot about the importance of getting a second opinion and just finding that right doctor who is willing to fight right alongside you to save your legs as well as your life. I'm joined, of course, by Dr. John Phillips. And guess what, John? This is episode 1 of year 2 of our show.
What a milestone, huh? And I think the fact that it sounds like it'll be mainly just a kind of a save my piggies type story, which is near and dear to my heart. Another thing that I guess is near and dear to both of our hearts is the conference that we were both at in Louisiana. So we got to see each other, 3 times in the last 3 months, and then prior to that, we'd never met in person. So we're a lot of big milestones the last couple of weeks for us. So how you been?
Fantastic. And we had a really big leg save this week, and it still warms my heart. This young 30-something African-American gentleman, full of life, in North Carolina, whose doctor had taken one toe. He had a little bit of gangrene on a couple of toes. And at that point, the podiatrist said, you need to go back to your vascular surgeon. And here's a 30-something with peripheral artery disease, 30-something, so much more life to live, right? Still single, trying to date the ladies. And he's being told that he needs a below-the-knee amputation. He found us online. Actually, one of our fellow network PAD warriors, as we call them, for peripheral artery disease patients, those who are fighting for their life and limb, ended up seeing him on a different site and steered him to the Way to My Heart to help him with our Leg Saver hotline. And we were able to get him to, and I have to say, Dr. James Antizana over in Charlotte, North Carolina. And he calls me and says, why a below the knee amputation? I could literally save his leg like that. Not even a consideration. So just on Tuesday, he brought him in. Within an hour, he was able to unblock the artery, send him on his way. And he said, no amputation is needed. So really, really exciting. And it was the day before his amputation was scheduled. He got to cancel it.
That's awesome. I had so we were at the conference. I was only there for a couple of days. And then when I got back on Thursday, I had office hours, and then I went to the cath lab, and I had met a patient that was referred over to me for like a third opinion. He was actually in the hospital, and this was one that we couldn't save his leg. They had taken some images, and the poor gentleman had just let it go too long. And the thing that always I scratch my head with the PAD folks and those that have really significant vascular diseases, because it often starts with just something benign like an ingrown toenail. So this gentleman had an ingrown toenail like 2 months ago, and he kind of picked at it, and then it just didn't heal, and it progressed to gangrene, and now he's gonna lose his leg. Like, there's nothing that we can do for him, unfortunately. But conversely, yesterday, similar thing, I saw a woman as like a third opinion. We finally got her into the cath lab, and it was the same deal. She had picked an ingrown toenail, and she's going to lose one of her toes, but was told by a couple other physicians that she needed a below the knee amputation. And it took a while, but we got that a couple arteries opened up, and I think we're gonna save her leg. So today, like this week, I had the both ends of the spectrum. I really hate telling patients that there's nothing we can do, because it feels like we're kind of quitting a little bit. But also, I do say, when I meet a patient who has no other option that needs an amputation, I want them to get that amputation as soon as possible, because think about it, they haven't moved around, maybe walked or put weight on that leg for a while, and the longer they're debilitated, the more muscle mass they lose, and the harder it is to get back into that prosthesis. So I don't know that there's a silver lining there, but again, we try to do because we were talking about this before the show went on, we all try to do what's right for the patient. And certainly you had a big save this week as well. So congratulations.
Thank you. It's hard either way. And one of the things we always tell our patients is you need to ask your doctor, what is your threshold before amputation? How are you exhausting all efforts? To what extent do you exhaust all efforts in trying to save my life, my limb? And it speaks volumes for you. You mentioned those conferences that we saw each other at, some of the most prestigious limb saving conferences in the world, with some of the best limb savers. And it was so great to see you on faculty for these conferences. And I think that that's a good criteria for some of these patients to use. Look at the conferences, talk to your doctor about the conferences they're going to, Google their names, see what conferences they're affiliated with and in which conferences they're faculty. And I think, and the presentations they give, you can see a lot and learn a lot from the title of their presentation. So I think that's really important. And I actually saw Dr. David Allie, surprising. It was just like, whoa, of course he's going to be at one of these limb saving conferences. And it was great to see you, Dr. Allie, this week.
Well, my dear, it was great to see you, but I have to admit that's the first time in 14 years I've made it to these conferences. I was a part of all of that starting it many, many years ago. So I'm smiling because I saw you and because I'm good to reconnect back with a lot of the things that actually I was among the first to do some of that stuff. And it's great to be reconnected again. And you have been a part of getting me back connected.
I love that. So exciting. And it still speaks volumes. You don't have to really go to one of these. You defined these conferences, and you're so busy every single day with so many patients. I mean, how many cases are you doing a day these days?
Well, it depends on the day. Sometimes on Sundays I don't do any, you see. I'm kidding.
Sometimes you do, but sometimes you do.
Well, you have visited us. I've surrounded myself with maybe one of the best teams ever. And the things that Dr. Walker does, are similar. As you know, me and him were partners going back 30 some years ago.
Right. You both started
anyway,
the NCBH
the answer
conference.
to that is I can sometimes do a dozen cases a day. And I'm getting to the point where I shouldn't be doing that many. And I pick and choose and have myself some partners. And when we talk to Mr. Thomas here, I'm going to tell you that I have done this for 45 years, and I will tell Mr. Thomas I have not seen a patient like him in my entire career, and we'll get into that, how unusual this case really was.
That's a heck of a segue.
That is really coming up. We're going to hear Thomas's story and the fight to save his limbs, so you don't want to miss it. Stay with us right here on the Heart of Innovation and our Save My Piggy special.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Oh, Kym, I was going to cut you off. I'm sorry. I was so excited.
We're just welcoming everyone in tandem. I love it.
Well, we are. And I was just thinking to myself, we burned through that first segment so quickly. We're going to have to be a little bit more terse in order to get to the meat of this show, which is Thomas and then Dr. Allie, right?
Yeah. And this is our Save My Piggy special. And we'd like to introduce Thomas. He's been waiting there patiently, and we just applaud his courage for being here. And, throughout, I'm sure that Dr. Allie has looked at all of his records. He's so diligent and detail oriented, looked at all of his records leading up to the point where he's gotten involved with treatment. So Dr. Allie, at any point during Thomas's story, feel free to jump in to clarify anything that would help our viewers and listeners understand his story and any lessons that they can learn along the way. But welcome, Thomas. Thank you so much for being here and all your courage and your inspiration that you're going to provide.
Thank you.
So let's get right to it. Peripheral artery disease, circulation issue affecting mainly the legs. When did you start feeling the initial symptoms of leg pain, leg cramps, weakness, heaviness in your limbs?
It was March 2021, when I started feeling the real weakness. I was actually at work. I just started a new job. I took about 10 steps in my left leg. It just wouldn't, it didn't want to play. It didn't want to move. It was so painful. I never understood it. I thought it was muscle cramps. And I had to go home early from work. And I thought, okay, I'll rest it. And then the next day, I'm going back to work. Well, it gradually just got worse over a week. It wasn't until I got to see a specialist, a cardiothoracic surgeon, where they did I can't remember the name of it, where they were trying to look for the pulse in my ankle. And he's like, Thomas, you need to have emergency surgery. You have no pulses in both your ankles. And I was like, isn't that a bit strange? You know, I've got no pulses, but I'm still moving around. I'm still walking.
Hey, Thomas, can I just interject real quick? Because what you
Sure.
said, I think it always sparks my interest, because it's a common complaint that I hear from patients. And as an interventional cardiologist, and Dr. Allie as a cardiothoracic surgeon, when people have chest pain, that sets alarm bells off, and they often seek medical attention. So, okay, we don't want you to have a heart attack, but a lot of patients have kind of that acute limb attack, and they kind of think it may be a muscle cramp, and then it gets put off, and then ultimately a few weeks later, we hear from them. So folks that are listening, please don't ignore your body. If something, and I think our guest last week too, to some degree, she had an acute onset symptom that really triggered, ultimately some workup further along the way. But please don't ignore your body.
And what's interesting is, prior to coming on today, Thomas, you had mentioned that even prior to 2021, you did have symptoms back in 2016.
Mm-hmm. Yes, ma'am.
That gave us some indication that should have given doctors an indication that you had PAD.
Yeah, that's right. Because I had pain in my hip, and it wasn't in the hip, it was to the outside of it. So when I went to my doctor and I told him, when I walk so far, my hip starts to hurt, and then my buttock starts to hurt, and then my calf, it was like it went from one extreme to another. So he sent me off for a CT scan, and he did tell me, I think he had an inclination in his mind, but he wasn't sure. He told me if he didn't find what he could find on a CT scan, what was wrong, he was sending me for an MRI. Well, the MRI, it actually got denied. It wasn't canceled. My insurance denied it, so I never got it. And then, but I did notice, though, over the years between then and like up until present day, it had started getting worse the more I walked. And I just didn't understand it. At that time, I did have to go in and have 2 stents done in my heart. A previous one had to be reopened, which was the LAD. They told me I had complete heart failure with that. And then the main coronary artery, they had to open that up. And, it was just strange how all this happened. But after that surgery, I was good with my heart. I've stayed good with it. I learned a lot from it. I learned to listen to my surgeon, not to say, okay, well, I can get away with doing this. Or, at the time I was still smoking cigarettes. But after that, I was like, no, I can't keep doing this. I don't want to die. I was so afraid. And then it went to, after that, all this started happening. It was nothing to do with my heart stents or anything. It was strange how it happened to me.
Now, Thomas, so ultimately you're being evaluated by a physician for the leg discomfort, and then you get told you need emergency surgery. So what are the next steps there? What were they planning on doing for you?
All right. This is where it got really kind of strange and weird for me. They took me to the day of the I was meant to have a stent put in. It was meant to be in my left leg. Well, for some reason, they said they couldn't get in there in the left leg. They looked in the right leg. And I was only down in surgery, I think maybe 10, 12 minutes before I was back out being told, look, you have to have emergency surgery. We're waiting for your insurance, to clear it so we can do it. And it was a bypass. Femoral to popliteal and femoral to femoral on the left side from the right. But the problem was that
So that was so they needed to do a fem-pop bypass, which is from the thigh to just below the knee, correct?
Yes, ma'am. That's right.
And then you said there was also a fem-fem, which is thigh to thigh.
Yes, ma'am.
Where they reroute blood flow from one leg to the other leg.
Yes, ma'am.
Both at once?
They did it both. They did 3 different things at the same time.
Wow.
The problem was always the left leg. It was so painful. The right was it was very light pain in it. It wasn't too bad. Now after they did the fem pop and the fem, I believe it was in that order. The surgeon, he was from Texas, but he was in it with a group of surgeons. He can do surgery all over the country. Well, he told me, he said, Thomas, you were in surgery so long because we had to do I can't remember the name. He cleaned out the artery. And all I can think of it is rotated it. He went through there. That's what took so long. And after that, I had a lot of problems. I had a lot of other problems down to this surgery. Can I go on about the other problems with my other organs?
Well, we've got about a minute left before we go to our next break, so we'll probably have you pause for a second. But so ultimately, you had these 3 surgeries, and you were presumably discharged from the hospital. And then when we come back from break, you're going to tell us how you were doing, because it sounds like you didn't feel any better, or things got worse.
I didn't do good. It got worse. It got worse.
Gotcha.
Great. Well, coming up right here on the Heart of Innovation, we're going to hear more from Thomas's story, and of course, hear from Dr. David Allie, who is treating him now and fighting to save his leg. So stay with us. Hi, everyone, and welcome back to the show. We are sharing Thomas's story. Thomas is alongside his new cardiothoracic surgeon. He is fighting to save Thomas's leg, and they're both working together on this. Before the break, Thomas, you were sharing that you had multiple bypasses done, a femoral popliteal bypass, which is from the thigh to just below the knee, as well as a fem-fem bypass, which is rerouting blood flow from one leg to another. And then on top of that, you ended up with a little, what you described as roto-rooting, where they go in with wires and balloons and maybe what they call an atherectomy device, which is a plaque removal device, and remove some of that plaque. How are you doing now, or how are you doing, let's say, following that?
Do you mean from when I started seeing Dr. Allie?
No, before Dr. Allie, because we're going to get to what led to Dr. Allie.
Right. Well, it was a couple of weeks later, I had a home health nurse coming out, and they would come around and do my dressings. And, they told me I could get up, I could walk to the bathroom, which is only a short distance away, but I got a different pain this time. I was getting like a shooting pain coming up from my toes on the right leg, right up to my groin. And it was a real weird feeling. It wasn't a pain, it was more a sore, but it was in the groin area. And then 2 weeks after that, I went back for a follow-up. When I went to follow up with my surgeon, I got to his office and I was told, you won't be seeing your surgeon today. He's no longer with us. He's gone somewhere else. And I kind of got upset, and I thought, oh boy, did something go wrong with it? And I've seen another surgeon. I believe it was a surgeon up above this surgeon who did my surgery. And he told me I had infection at the time. That was the first thing he told me. I had infection in the groin. And he told me the only way that we will remove that graft that we put in is if the graft becomes infected. And this went on for like several months. I panicked because the surgery, what it had done to me. And I was so afraid I was going to lose my leg, or, you know, and it built up on me. Well, anyway, after I believe it was after maybe 4 to 6 weeks, they told me the graft had failed. Both of them, the fem and the fem-pop had
So
failed.
Thomas, if I could interject, because I want to hear from Dr. Allie, just so we can get a little bit more color behind this. So I guess a couple of thoughts that come to mind. Maybe the first surgeon was a locums and was just kind of spending a little bit of time there. And then the second thing, Dr. Allie, I'd like to hear from your thoughts. So presumably the incision got infected, and then that ultimately led to the graft. Maybe it failed because of outflow issues, but then the graft got infected also.
Well, guys, tell me when I'll come in with some clinical stuff, because you're close, but you're not exactly right on all of this from the standpoint of medically and what I was faced with and what I decided to do for him.
I'd love to hear.
Yeah,
we'd love to hear from that point. Yeah, no, exactly. We'd love, because we're just guessing.
We're pretty good guessers.
Well, yes, you are, and so was I, and that's always good to have luck on your side, okay? But there's things that had to be proven one way or the other. So Thomas is a fellow who was a smoker. He was not a bad diabetic, and that is important because he never had digital ischemia, and that is hard to overcome. He had a normal kind of atherosclerotic process in which smoking in relatively small vessels for a male, and he was suffering from PAD symptoms for several years. And as I look back on this, he had significant disease. It was kind of identified, and the treatment finally came, it appeared, when he had really had a occlusion worsening some of his chronic disease. That brought his symptoms on, but they weren't at his toe. Many of your audience is going to be diabetics. The normal thing is it starts from the toes up. That, luckily for Thomas, was not his case. His ischemia was to the muscles and into the larger blood vessels. Now, with that said, when he went in for treatment, I believe, he was seen by vascular surgeons who I will say, I would hint are adequate and were good, yet he was very complex. This was a very complex anatomy that he presented to these physicians. That same kind of case had presented, let's say, to somebody who had more endovascular training or skills to do things with wires versus open surgery. I see that all the time, and I'm lucky enough to have a staff in which we can correct most things like Thomas without ever having to go to open surgery. Now, that doesn't mean there's not a place for open surgery, because there occasionally is. In his case, he did not have anatomy and the situation that was conducive to fixing without an open surgery. They made an appropriate decision, I think, in their hands, that they would now offer him surgery because they were concerned about the limb. They chose a fem-pop bypass, which is complex. I have done them. They are recognized procedures, but they are complex, and there are risks and benefits. And one of the things that Thomas suffered from was, first of all, his revascularization, or the bypass, did not work the way that was proposed, and I doubt that it worked very long at all. So in their attempts to correct his circulation, he had an open surgery procedures. Anybody who has these open surgery procedures have a risk for the wounds not healing where the incisions were at. He had a long bunch of incisions. There was, even if this had worked, it had 10 to 20% chance that he may have kind of a wound complication. That
Right.
goes back to one of the reasons why it is always, in 2023, we should have endovascular procedures, which are non-surgical procedures, in almost every patient as the first line of treatment that will revascularize and save most of these patients without an open surgery.
Dr. Allie, I hate to interrupt you, but we're going to go to break. But I also want to just make sure I heard that correctly. As a surgeon, you're suggesting we should go to endo first. I mean, I do endo first because I don't have the opportunity to flip, but I like what I hear. And
well, this not brand new. This goes back to the days of Tom Fogarty, Ted Dietrich. In other words, we have the surgeons who realize this are they're few, but there's more now than there used to be. And so I think it should be well accepted, even by most surgeons, okay, who now have those and are taught those skills because they weren't before. That the patients out there ought to go somewhere where no matter which physician you see, it should be optimal that all endovascular non-surgical treatments are offered first. And that's what you saw.
You are so preaching to the choir here. We love you, Dr. Allie. Coming up next, right here on the Heart of Innovation, we'll have more with our Save My Piggies special, and we'll continue Thomas's story.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. This is our Save My Piggy special. We have Thomas here, who's been sharing his limb-saving story alongside his cardiothoracic surgeon, Dr. David Allie, and we're going to get to the point where Dr. David Allie started treating him in this segment. It's a short segment, but let's just get to the point. You ended up getting in touch with the Way to My Heart, which is our leg-saving nonprofit organization, and our nurse practitioner at the time said, Thomas, you have this infection. I need you to go right now to the emergency room and get some antibiotics. You said, okay, I'm going to go to my local hospital. I'm going to get the antibiotics. And what happened while you were there? They said, we're not just going to give you antibiotics. We're going to cut you open again, right?
Yep. Yes, that's right. They told me I didn't have no infection. But they put 22 vials of antibiotics through an IV.
But you had no infection.
No, I had no infection.
That's what they said.
Absolutely none. And but but you could see it. It was oozing. It was brown. It was all colors. It was really hot. It was nasty. And this was
at the incision site of your last bypass.
Yes, right. Ma'am. Yes, it was. And it was just above the knee, where there was one little cut, I guess, where they come down from the groin down there. And there was like an area where I've got like a 3-inch scar. And then down below the knee, that was above the knee, the 3-inch scar. And then the one the one below the knee was about 6 inches. Wow. They were both infected.
And so you actually in this moment decided, I'm not doing any more cuts. I'm going to do as the Way to My Heart suggested. I'm going to go get a second opinion. And that's when you went to Dr. David Allie. You checked yourself out and said, I need another doctor.
Yeah, this was actually a third opinion because I had the second surgeon. The strange thing was they kept telling me, you need a bypass. I said, I just had a bypass there. And they're like, no, you're going to lose your leg. We're going to end up having to amputate it if you don't do this bypass. Well, in the end of it all.
So Thomas, when you decided you've had enough, wanted your third opinion, and real quick, what did the doctors think when you said that? Hey, I'm leaving.
They told me I was refusing treatment, which I wasn't. I wanted that opinion, that third opinion. I have that right to it. And I asked about the antibiotics, why they were pumping so many antibiotics through me if I didn't have infection. And then my main concern was they wanted to do a surgery again, and I had infection, which would end up spreading right through my whole body. Well, anyway, long story short, from this guy that I've seen up at ER, he told me, like, you're refusing treatment. The surgeon's back tomorrow. I said, no. I said, I'm going home. I'm going back to work. You know, I was adamant. And after that, No, they won't see me at all up there.
And so, Dr. Allie, you jumped in, and what did you find when he went to see you?
Okay, guys. So he presented to me. He's described surgical incisions that were about to completely fall apart. So when he came to me, the first thing I had to do was to try to determine whether or not this guy needed an amputation. Because in truth, if his graft was infected, it would have to be removed, and at that point he would have had to have an amputation. And what is also not said here is he's had multiple knee procedures. So there was a lot of things going on there, and I had to determine whether this was superficial or deep infection of the graft. Now, he happened to land in my hands, and as a surgeon, I also happen to do advanced wound care. I'm hyperbaric certified. I do all of these other things that are ideal for wound care also. I determined, because he wasn't diabetic, he had no ischemic on his toes, that if his wound was superficial and it was superficially infected, which it was, that is different than a deep infection. So I had to prove to myself, and this was done by quick testing, including an MRI. This meant that he did not have a deep infection. Everything was superficial. And if I could get him some additional blood flow and treat his wound, then he didn't have to have an amputation, but that he would need complex wound care, skin grafts, all of those things, which I was willing to do. And understand, Thomas could still walk. So he did not have anything that did not give me the time. So I also wanted to see if I could help him with revascularization without surgery. So I did an angiogram, which means I took him to the cath lab from the arm, and I sought ways to help him with wires. The answer is he had no wire accessibility to revascularize him.
So, Dr. Allie, I'm gonna. Sorry to interrupt you, sir. I'm gonna have you stop right there. We need to go to break, but once we come back, you're gonna finish the story for us. So, stay tuned, please.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
So we only have about 5 minutes left. Dr. Allie, you were beginning to tell us about your kind of treatment plan for Thomas. But before you do that, and I hope you get, or at least get into it, because you had told us before the show started that you had never seen a case like this. So expand on that, please.
I'll do that. Can I do that now?
Please.
Yes.
So to the audience, he presented with infection, ischemia without blood flow, draining wounds, the possibility of graft infection, knee space infection. The reason I'm telling you that is because almost every case like this would have already had an amputation. And that was what he was probably looking at, but because I don't think he had any abilities to have revascularization. Now, with that said, so that puts him at the end of the whole scope, and I see patients at the end, but most of those patients, again, have digital wounds. They have things that cannot, that rapidly go into gangrene. He had ischemia, which means a lack of blood flow, but he wasn't in acute need for an amputation, nor revascularization, nor anything at that moment, in my opinion. So we took an angiogram. He had no options to get him more blood flow. Not, in my opinion, not surgical and not with wires. So therefore, I was focusing on a massive wound in a patient who didn't have much blood flow. But I felt, because of my clinical experience and what I'm seeing, is that he had enough blood flow to heal his wound if we could keep it from getting a deep infection, because he could still walk. So I had to make a decision. Was I going to take this on? Because there's people who are looking at somebody like myself. Is he doing too much? Is this really a non-salvageable situation? So I made a clinical decision that I think I could work with this patient for those medical reasons. And I had a patient who looked me in the eye and he seriously wanted to save his leg. I had Kym McNicholas. I had the foundation. I had them Ubering him back and forth. This wasn't just David Allie. So I was compelled to help this gentleman and go through the process, starting to treat the superficial infection, treat the wound, do the best I can with those skills, because I had those other skills, but they weren't applicable to him.
So David, we've got less than a minute left. So tell us where you're at right now with his wound care.
So I made a decision, and we did complex debridements. I proved that it was superficial. I put on split thickness skin grafting. We now have this thing almost completely healed. He walks, he get around. I met his wife. And may I throw in that during this several month period of time, I was in the hospital myself, the floor below Thomas, with acute kidney stones. Thomas, you remember that?
Calling the shots
Yes,
to help Thomas. It was amazing.
And so,
Yeah.
so this was a very complex case. This deserves the audience understanding. Get multiple opinions from multiple physicians. Rely on Kym. She knows who can do the wires, do the stents, do the surgeries, do the wound care. And this is a very complex case. And at this moment, we got a fellow who's smiling. He don't have no cigarettes. He's responded. We've got him on maximum anticoagulation. His wound is almost completely healed. And to my knowledge, we're going to get it healed. And I will continue.
That's fantastic. I have to ask, Thomas, did you lose any digits, or have your piggies been saved?
My piggies have been saved, every one of them.
Oh,
And
amazing.
Guys,
that's a
the very
blessing
first, the very first question I ask him every time I walk in is, "How's your toes?" Because you understand that now puts it in a different category.
Yep. And so now, do we have a long-term leg saving possibility here?
Yes, we do. We do. He has no imminent wounds. Now, he got to take care of his toes, because if he does have a wound, if he has something like that, he has very little
30
flow.
seconds.
Enough to save his leg, enough to keep him ambulatory and walking, have a smile on his face, and enjoy his life. The wound care has been complex. He has allowed it to happen. I have provided it, and here we are today.
Thank you so much, Dr. David, Allie. We really appreciate you. Thank you, Thomas, for sharing your story.
That's fine.
Thank you, all of you, for joining us on our Save My Piggies special. Have a great weekend, everyone.
The Heart of Innovation is for educational and informational purposes only, and advice and views shared are not a substitute for medical advice from your own supervising physician. Do not act on any information provided in this show without the explicit consent from your own healthcare team. If you think you are having a medical emergency, call your local emergency number or go to the nearest hospital or emergency room.